Welcome to the Cardio Academic webinar. Today is a special day. We will analyze a very important trial, the Ischemia Trial. And our objective to answer a major question is what's new for stable ischemic heart disease patient? I am Dr. Gary Naib, an interventional cardiologist at the National Institute of Cardiology in Mexico City. We have as coordinators to my friends, Dr. Marco Alcocer. He is the president of the Mexican Society of Cardiology. Marco.
Thank you, Gary. Good afternoon, everybody. We was talking a few minutes ago that this kind of communication is going to be very necessary in this time. And I'm very happy to participate in this modality on Cardio Academic. Thank you, Aloha. Thank you, Eric, to invite us. And obviously to our great speakers, Haile Wilson, thank you to be with us. And obviously to Rafael Lopez. He's going to be our first speaker. He's a very fan of us. He is participating in a lot of activities in Mexico, and we hope to keep inviting you, and you accept to visit us for the future. And he's going to start, as you know, Rafael is specialized in nuclear medicine, and I want you to explain us if we are going to still use this kind of technology, or this study tell us that we are not in the necessity of using nuclear medicine studies anymore. What is your opinion, Rafael?
Thank you, Dr. Gamba, for the introduction, and thank you, Eric y Aloha, for the invitation. Gracias por la invitación. Yo voy a hablar en inglés. Entonces, are you seeing my slides? I think it's okay, yeah? So, to start, I have no disclosure. Although that I'm a nuclear cardiologist, and so I practice nuclear cardiology daily. This is a very important trial, as Dr. Alcocer Gamba told us, the Ischemia Trial that's presented in the American Heart Association in Philadelphia in last year. When we have to talk about ischemia, there's some concept that we have to keep in mind. It's not so simple. We have to address the whole physiology of the heart. So we have to think about the stenosis, the flow, the phenomenon of the perfusion, and also the ischemia, the imbalance of the perfusion and the metabolic address it for ischemia. So we have to keep in mind not only the epicardial vessels, but all this network of the microvascular net that is responsible not only for the flow, but also for the perfusion and the coronary reserve. So what are the literature about it? So before the Ischemia trial, in the era of the randomized controlled trial about optimal medical therapy, we have two trials that are very important, the Courage, that are very kind to us, and of course the Barry 2D. Both of them were negative, considering the medical therapy versus interventional strategy for heart events in cardiovascular, in chronic, coronary chronic syndrome. And of course, we have a great advance in the interventional cardiology with the advance of FFR, the fractional flow reserve. And there are some pivotal studies like the DEFER, the FAME, of course, that shows that the physiology addressed by intervention by the FFR is better than guided to only to angiography. And they have the FAME2 trial that also addressed the question of interventional guided through FFR versus medical therapy. Although this shows benefit in urgent revascularization, we have no benefit in deaths in myocardial or myocardial infarction. And this is shown by also this meta-analysis. So this is the literature before the Ischemia trial that, that shows that PCI versus medical therapy alone in patients with stable obstructive coronary artery disease and myocardial ischemia. In all these meta-analyses, including the MASS2, the BARI2D, the COURAGE trial, or even the FAME2, there's no benefit in these stable patients for heart events, especially death, myocardial infarction, or cardiovascular death. Oh, well, this is a seminal trial that is an observational study by Dr. Hari Hakimovich. The revascularization was associated with a lower cardiac risk of death only for those patients with more than 10% ischemia on perfusion imaging. And this is where we started to think about to be more intervention to the patients with more ischemia and to be more conservative to patients with less ischemia. So the paradigm that ischemia suggests is why the randomized trials have not demonstrated the survival benefit for revascularization in these patients before. There's a lot of questions about the severity of obstruction, considering the angina, but the no rupture of plaque, this versus the mild obstruction in patients with no angina, but is more likely to be ruptured. So vulnerable plaque, minor obstruction, eccentric plaque, lipid pool, all these features have a role in this scenario. So this is the prior trials, the strategies, the landmark trials. And I want to show a person that's much more experienced and much more better than me to talk about this.
Ischemia trial is interesting because it's a culmination of two prior trials. The COURAGE trial, which is a Department of Veterans Affairs trial published in 2007 in stable ischemic heart disease. So the importance of ischemia or stress imaging ischemia in relation to guiding therapeutic decision-making, either medical management alone or coronary vascularization. This was followed by a similar trial called BARI2D, was published a couple years later in type 2 diabetics. Both of those trials were negative in terms of establishing the fact that revascularization doesn't improve outcomes in patients with ischemia. And now we've followed this up with the Ischemia Trial. It's been a 7-year trial, 7 years of working on enrolling patients from 300 medical centers, about 300, all around the world. So China, Russia, Canada, Argentina, Brazil, and the United States, and Mexico. I could go on and on. 5,000 patients have been enrolled. We enrolled patients with moderate to severe ischemia. So this is a much higher risk population than's been seen in other trials. Patients are being randomized to cath versus no cath, and whether or not we see that revascularization improves outcomes in patients with stable ischemic heart disease, but very high risk ischemia. So it's a critical question for us to establish the benefit of revascularization in this population who's more elective in terms, it's not the acute populations, it's not people who are having a heart attack or an MI, acute coronary syndrome, it's people with stable ischemic heart disease. A critical question for management and how imaging can be used to guide therapeutic decision making, which, as you know, is critically important for us to make that link between imaging findings and therapeutic decision making. It's an exciting trial, and we're looking forward to finding out the answers in the next year to 14 to 16 months.
And one of the
This was recorded in NASNIC meeting in 2008 in San Francisco, where Dr. Leslie Shaw addressed it to the question of the ischemia trial. So we have to have in consideration if we'll higher risk patients based on substantial ischemia benefit. We have to eliminate the referral bias by randomizing before CATs and use a new stance in FFR as needed. So this is the limitations of the prior trials, the BARI2D and the COURAGE. There was no randomization before CAF. There's no minimum threshold for ischemia. Drug-eluting stent was not used in COURAGE or in BARI2D. PCI guided for FFR were not used also in COURAGE and BARI2D, and CABG is not doing COURAGE or in FAME2. So the question that came with ischemia is all about the treatment strategy trial. The question they want to answer is, in stable patients with at least moderate ischemia on a stress test, is there a benefit adding cardiac catheterization and, if feasible, revascularization to optimal medical therapy? So I'll try to give you the perspective of imaging physician, of course, a nuclear physician, but an imaging physician. And what I like about the ischemia, and I like this phrase, that ischemia is much more about courage and not about promise. So although comes the question about start with CT or nuclear or other functional tests, the ischemia does not address the question, the value of the function or the anatomic imaging in patients with suspected chronic coronary syndrome. But this is the design of the ischemia. The patient, most of them symptomatic, they have a stretch of functional tests, mostly nuclear, but echo, MRI, and we have also 25% of AKG stress test. We're gonna tell a little bit more later. Then, and when they're gonna to a blinded CT, and then they're gonna be randomized for conservative or invasive strategy. Let's overview with the New England Journal quick tale about the trial, and we continue.
For patients with stable coronary disease, reducing the risk of ischemic events and improving quality of life are the main treatment goals. Investigators in the Ischemia Trial examined whether adding a routine invasive strategy to medical therapy would improve clinical outcomes for these patients. This multi-center randomized study enrolled 5,179 patients with stable ischemic heart disease and moderate or severe myocardial ischemia. 2,588 patients were assigned to receive invasive first management, including coronary angiography with revascularization if indicated, in addition to medical therapy. 2,591 patients were assigned to receive conservative management, consisting of medical therapy alone, with angiography reserved for failure of medical management. The primary outcome, a composite of cardiovascular death, myocardial infarction, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest, was met after a median of 3.2 years by 318 patients in the invasive management group, as compared with 352 patients in the conservative management group. The hazards were not proportional. At 6 months, the estimated event rates were 5.3% with invasive management and 3.4% with conservative management. At 5 years, the estimated event rates were 16.4% with invasive management and 18.2% with conservative management. Results for the major secondary outcome of cardiovascular death or myocardial infarction were similar. Using a secondary definition of myocardial infarction, the primary outcome event rates were higher in the invasive group throughout follow-up. All-cause mortality was similar and low in both groups. In this randomized controlled trial, the investigators did not find evidence that routine invasive management reduced the risk of major ischemic events when compared with optimal medical management in patients with stable ischemic heart disease. The trial findings were sensitive to the definition of myocardial infarction used. Full trial results are available at nejm.org.
I think this is pretty straightforward and been simple, but now I'm going to address to some questions, of course, in the perspective of the imaging physician. So this is the study design. So we have the patient with stable but moderate to severe ischemia. Then if they have, they not require an CTA if they have a low glomerular clearance, the creatinine clearance between 32 to 60 millimeters, and or if they have a previous known anatomy. If they don't have this, they go to a blinded CTA. The core lab decides if their anatomy is eligible or not. Then they randomize the patients. This is important to have in mind that the CTA here, the blinded CTA, is an equipoise. Equipoise is what, or clinical equipoise or principle of equipoise. This provides an ethical basis for medical research that involves assignment patients through different treatment arms. The situation in which things are perfect balance. That's what they aim to add in the CTA to the study. Okay, that's not necessary for the patients for having the CTA, but for the clinical aspects and the ethical aspects for the study, you have to know if they have left main or if they don't have actually obstructive disease more than 50%, so that the arms would not be comparable. That's a clinical question, okay? So this is the endpoints, and I'll go through here very quickly. The time to cardiovascular death, MI, hospitalization for a stable angina, heart failure, and resuscitated cardiac arrest. The second endpoint, time to cardiovascular death or MI, and quality of life. This is important later. The study considerations that the groups were analyzed by intention to treat. This is very important, and a median follow-up of 3.3 years, and more than 99% of the patients were followed up. So this is a very good follow-up. And the power of the study, the power is more than 80% to detect 18.5% of relative reduction in prime endpoint for a greater 4-year cumulative rate, approximately 14%, and a precision of 95%. The criteria. They are pretty straightforward criteria. The patient needs to have at least moderate to severe ischemia. It was the definition was for nuclear more than 10%, or some of the different score more than 7, echo more than 3 segments in stress-induced moderate to severe hypokinesias or akinesias, CMR more than 12% myocardial ischemic, or low motion in 3 to 16 segments. And this is the point I'll talk a little bit more later. The exercise tolerance test, or the treadmill test, downslope of 1.5 millimeters in ST depression in more than 2 leads, or 2 millimeters ST depression in a single lead with less than 7 METs with angina. And for this patient, it's important to have in mind that the CTA, the obstruction lesions with more than 70%. This is what I call it. So the criteria for CTA eligible is more than 50% stenosis in a major epicardial vessel. And if the treadmill test was positive, it would be more than 70%. What are the exclusion criteria? Important, more than 50% in a left main unprotected. And if the clearance was lower than 30 millimeters per minute or on dialysis, these patients go to the ischemia CKD. The endpoint definition was also pretty straightforward. I don't stay main time in this, the cardiovascular death. There's a question about myocardial infarction, so, but we're gonna address this later. And unstable angina, heart failure, and recessive cardiac arrest. But the study flow, what it shows, in the case of, we have 80,000 patients were enrolled, but only more than 5,000 randomized. The study was, the CTA was performed in 73% patients and randomized to more than 2,050 patients for each part of the study. So conservative or invasive strategy. For the patients included, 90% of them have angina, 70% of them were submitted to functional imaging, and only 25% of them had a treadmill test only. It was remarkable the small proportion of women, only 22%, and a higher prevalence of hypertension and diabetes. 32% had moderate ischemia and 54% had severe ischemias, or more than 80% have moderate to severe ischemia. So this is important, and more than 87% affected the anterior descending coronary artery, and almost 50% have triple vessel disease. So in the imaging perspective, this is shown here in the qualifying stress test by the core lab. What I told you before, 50% in the invasive group and 55% had severe ischemia, and moderate ischemia 34 to 32%. Both of them similar in the invasive, in the conservative group. And still in the perspective of the imaging and by the CTA, as I told you before, almost 50% of them have triple vessel disease, and almost 90% had left the anterior descendant artery compromised also. This is the medication used over time. There's no much change, only for anti-anginal medication, and this is, we can talk about later when you address to the angina-free follow-up of this patient, the quality of life. But in conservative strategy, there are more use of anti-anginal medications. And of course, in the invasive group, in the initial months, there were more use in dual antiplatelet. Of course, the cardiac catheterization, revascularization, I would like Dr. Hadley address this much better than myself. And of course, also to the mode of revascularization, I would like to Dr. Wilson his perspectives. So I won't go much further in this. The primary outcomes, we already talked about it. It was pretty straightforward. There's no statistically significant difference in primary outcomes between the two groups, an average of 3.3 years, 15% in the conservative group and 33% in the invasive group. At 6 months, we had a more frequent in the invasive group, and in the 4 years, we have more frequent in the conservative group. The major secondary endpoints, the similar. I'll address it a little more quickly. The net clinical benefits also, no different. Cardiovascular death, all cause of death, same. Myocardial procedure and spontaneous myocardial. This is another curious observation when analyzing spontaneous MI, that only significant difference found between the invasive group. Nonetheless, the perioperative infarction episodes also happen in the real world and must be taken into account. The myocardial infarction, but when we include in the sub-analysis obvious larger invasive treatment group, the MI outcomes are the same in both same groups. For hospitalization and angina, hospitalization for heart failure and resuscitated cardiac arrest, there's no difference also. And there's no difference in any subgroup pre-specified analysis. But it's important to talk about quality of life. And this is where the things get a little bit tricky. The probability of angina in the baseline and the frequency, you can see that the patients were more frequent to have angina would be free from angina in the invasive group than they will be in the conservative group. But in this benefit was persistent for almost all the trial, and the difference was not shown in the end of the trial. This is a secondary outcome, but was found the difference in quality of control of life. Here, almost 40%, then 15% difference between the two groups. But in the end of the trial, there was almost no difference, okay? So, in summary, for the results, the curves across the primary endpoint and the major secondary endpoints are approximately after 2 years from randomization. The estimated rate of infarction in the invasive group at 6 months, and approximately 2 in the estimated in the 4 years in the invasive group. So we have more infarction in 6 months in the invasive group and less infarctions in the 4 years for the invasive group. The procedures MI were increased at the invasive strategy. The spontaneous MIs were reduced in the invasive strategy. All-cause mortality in both groups, despite the high risk of clinical characteristics of the high-risk ischemia and the extensive care. There was no heterogeneity of treatment effectiveness, including by type of stress, the severity of ischemia, or extent of care, and a very low rates of procedures related to stroke or death. And this was the conclusions Dr. Judith Hockman put it in the ischemia, that ischemia is the largest trial of invasive vascular conservative strategy in patients with chronic coronary syndrome. Overall, an initiative of invasive strategy as compared to initial conservative strategy did not demonstrate a reduced risk over a median of 3.3 years for primary endpoint of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest, and the major secondary endpoints for cardiac death or MI.
The Ischemia Trial, led by myself at NYU and my study co-chair, David Marin at Stanford, was the largest trial of its kind. It involved 320 sites around the world that randomized 5,179 patients. That's more than twice as large as any previous similar trial.
Brazil had almost 400 patients in the trial, almost 80% with 16 centers for this trial. And this is where I want to show you my perspective. The Ischemia trial is actually a media phenomenon, a media success. It's a more than 100 million trial. And in the presentation, look at the Twitter curve. the ischemia trial, during the presentation, more than 600 cardiologists had more than 2,000 tweets during the 75-minute sections, and the 7,500 tweets in the following hours. And this is what the media said about it. And this is, we have to take into account, but it's a little tricky, and we have to be the scientific perspective. They say that stents or bypass surgery are no more effective than drugs. I think we have to address this. We can't forget about what we learned so far, that the stratification of the risk of patient is important. From the Framinghart study, we have patients from low risk, less than 10% in 10 years. For those with the higher risk, more than 20% in 10 years. If we have the estimation risk of events from the group of the ischemia trial, in 5 years, it would be 16.5% invasive group and 18.2% in conservative group. Estimation about more than 3% per year per group. So this is where actually patients of higher risk. And the ischemia trial, this is a recent published paper in the Diabetes Care ahead of print in November in 2009 that showed that the SPECT is able to differentiate between the ischemic burden and the prognosis of the patients with diabetes and without diabetes. There's a difference, and the difference in the heart events, the MACE events, they grew up when the ischemic burden grew also. So we have to remember that advanced cardiovascular imaging successfully risk stratifies patients in many situations. This is point. And also have to take in mind the guidelines, of course, that were published before the ischemia, but the S guidelines from 2009, they use the non-invasive imaging techniques, the CTA or the ischemia, the function test for ischemia. And this is the recommendations class 1, level B. And this is a recent published by Sharir also that showed the same results that we see in the Hori Hakamovich trial. More than almost 48,000 patients, almost 8,000 patients with ischemia, more than 5%, and almost 180,000 patients in early revascularization, and showing also benefit. So the question maybe not finished addressed. This is also from Sharir, and I'm almost finishing. And this I would like to address because Eric has a large experience with PET, and this is an observational study also, but it's the largest study in investigation of data evaluation relationship among ischemia, treatment and revascularization, and long-term mortality in contemporary patients undergoing to PET MPI. And we show more than 16,000 patients, a follow-up of 3.7 years, 8% revascularization, 15% died, 37% had ischemia, and 13% have more than 10% ischemia. And we can see a benefit. With the greater the ischemia, the greater the benefit. So Dr. Murky addressed the question about we have not only patients with imaging techniques. The initial ischemia were planned to have only image techniques for stress test. But in January 2024, a protocol amended permit the inclusion based on EKG changes during exercise test without imaging. We know that ischemia was very difficult to realize. It's a robust trial, a well-designed trial, and face the difficulties that we face everyday practice. In October 2014, the operating procedure was modified to eliminate the need of the interpretation lab to enroll patients. This also may have some significance. But what Dr. Murty wanted to clarify is that the investigators from ischemia have a clear result to address the practical challenges in implementing such difficult trial. Nonetheless, we are likely to face many challenges is interpreting the results as they are eventually faced to make it public. So my final message to you would be, designing the trial, the ischemia was designed to confront different treatment strategies in coronary crohn's syndrome, not only reinforce but amplify the courage concept to adding value to optimize clinical treatment, even in patients with moderate to severe ischemia. Optimized clinical treatment can be as powerful as intervention, as should more often considered as initial option, and not just for those with little or no ischemia. Ischemia should give us a confidence to pursue the strategy of truly optimal medical therapy for both cardiovascular risk reduction, for angina symptoms relief. And from the imaging perspective view, we have to keep in mind that learning the functional consequence of a symptomatic patient was the starting point to establish the causal relation between symptoms and the obstructive lesions later seen or not seen in CTA. We have to remember that 14% had no obstructive disease greater than 50%. And this patient was also addressed in the CAO ischemia. And in the CTA, we have to keep also that the coronary anatomy knowledge of patients with suspected in coronary current syndrome was not questioned. The presence, the location of the lesions, the degree of obstruction remain relevant information. And the study result does not apply to patients with acute coronary syndrome, coronary chronic syndrome with ischemia and left ejection fraction lower than 35%, with neurocardiac association class of 3 or 4, in epicardial coronary lesions less than 50%, or with significant left main coronary disease unprotected, and the ischemia and limited symptoms despite optimized clinical treatment. And the best approach, and this is, I think, the most important message, for a patient with suspected coronary chronic syndrome is bring the patient to the center of decision, providing as many information as possible, clinical, functional, and anatomical data, and then decide what's the best managed. Of course, I think the Ischemia Trial is likely to impact future guidelines. And I'd like special thanks for the invitation to our team in Hospital do Coração in São Paulo. And I'd like to have a final message. The problem is not so much to see what anybody has seen yet, as to think what nobody has yet thought concerning what everybody sees. Muchas gracias. Thank you very much, you all.
Thank you, Rafael. I think you present us a very interesting information, and obviously, as you explain us, the individualization, and be careful about what study decide to include patients. Be careful, not all patients need the same treatment, obviously, because the time we are going to have the next speaker. We have some comments that I'm going to write in the chat because some of them ask questions, but I'm going to write some answers. But I insist you to appreciate your experience, and obviously the important evaluation of the non-invasive studies that actually is something that we need to be careful and not forgetting to have a very good evaluation on each patient. So thank you. And Gerin, can you introduce our next speaker, please?
Okay, thank you, Marco. And now we will listen the point of view of a very qualified interventional cardiologist. For this, we have in this opportunity to Dr. Hadley Wilson from ACC. And for the time, please, Dr. Wilson, go ahead, please.
Thank you very much. And thank you to all the meeting planners for being very flexible with Cardio Academic as we go on in this new age. And I hope everyone is well. And special thanks to Dr. Alexanderson and Dr. Moavi as well. Now, are my slides, can I share my slides? Can we put those up, or how should I share those? I think if I can share, it says,
yes, you can share it, Hartley, directly from your computer.
Yes, I have my PowerPoint up and I should be able to share, right?
Yes,
okay.
you can.
The host is disabled participant from screen sharing.
Yeah, go ahead.
Okay.
Try again, please.
Okay, thank you. There we go. There we go. Let's see here. Okay. Share. Okay. Everyone able to see the slides, I believe?
Perfect.
Oh, great. Thank you. And many thanks to Dr. Lopez. Raphael, that was an excellent summary of the ischemia trial, and it was very thorough, and I will try not to be redundant. You made some very excellent points, and so I'm asked in the next 15 minutes or so to give an interventionalist view, which I'm happy to share. I think, you know, I'm sort of in the corner here, but I'm going to try and do my best. I have no disclosures. And you already showed this slide, which was the blockbuster at the American Heart meeting in November with Dr. Hochman and Dr. Marin. And then you also showed the basic study design, which was guided by coronary CTA to not only rule out left main disease, but also to rule out patients who actually had insignificant coronary disease. And I think that's an important point as well. And the randomization and so forth you pointed out, I'll try and go quickly through that. I think you also really did excellent summary of the imaging and perfusion ways to qualify or include patients in the study. And I'll concentrate a little more also about the exclusion criteria as well as some of the inclusion and exclusion criteria from the coronary CTA in a minute. So you've seen most of these because you've done an excellent job summarizing that. And again, as you showed, the 18,000 patients that were enrolled, 5,000 that were up to randomization, and that gave over 2,500 in both the invasive and the conservatively managed group. And I think a very important point about ischemia is that, and I'll come back to this, you showed the European guidelines. I'm going to show again the ACC-AHA guidelines for stable ischemic heart disease, that it was not only an indictment of PCI or intervention or invasive therapy, but you can see here, I believe on the slide, that more than a quarter of the patients in the invasive arm were also treated with coronary artery bypass grafting. So you know, it's also makes us think more about some older mantra about coronary bypass surgery for double and triple vessel disease. And also we should note up here above that about a third of the patients that were ruled out had extensive disease that was considered unsuitable for any mode of revascularization. So this was a very preened or well-healed or very circumspect group that was used for ischemia. Now, you also showed this slide, and you made the point that early on in 6 months, the complications in the primary outcome were higher in the invasive group on the red line, and that was probably driven primarily from the procedural related MIs for the invasive group, but that the curves cross over at 2 years, and at 4 years, actually there's like 2%, more than 2% less complications in the invasive group compared to the conservative group, although this did not reach any statistical significance. And I think that's an important point because the primary investigators, Dr. Hochman and Marin and others, have really said that, you know, these lines are seeming to start to separate at 4 to 5 years, and something as large as this will probably never ever be repeated again because of the cost of these large patient clinical trials. But they are appealing to the National Heart and Lung Blood Institute and the NIH for additional funding to follow these patients out to as much as 10 years, and we may actually see a difference in the primary and secondary outcomes, may actually be better with the invasive group versus the conservative group at 10 years. And so we'll have to see if that happens, if they're able to follow these patients for 10 years instead of 5. And we know that from some CABG trials and from the left main Excel trial and others that following patients out further on in time can make a difference. So that's an interesting point, and we should continue to see if these patients are followed in the future. And the same is true again for the secondary outcome of combined of cardiovascular death or MI, that again, it started to separate at 4 years, and although not significant, that this may be impactful if these patients are followed much longer. Now, you also pointed out the limitations of the trial, which I think are also important, and I'll go back to that in my summary statement. So when we think about invasive versus conservative management after the ischemia trial, we have to remember that, again, this was a group that was really well selected, and they did not have any acute coronary syndromes within the preceding 2 months prior to these patients being selected. Also, I'll talk some more about the highly symptomatic patients. Of course, we know the left mains are ruled out, and we know those with even moderate heart failure, less than ejection fraction, less than 35% were also ruled out. And there are other sub-studies that are yet to be completed, including the completeness of revascularizations not yet been assessed, as well as the fact that there was a low enrollment of women in this trial as compared to the normal population. And again, from Dr. Marin's report at the virtual ACC 20 just a couple of months ago, again, he pointed out that the limitation could be that the follow-up now, the median is only 3.2 years. And he, along with Dr. Hopeman and others, are really pushing to see if they can have additional funding to follow these patients out, maybe up to 10 years, as I spoke to. The other was that the anatomy was defined by this coronary CTA and not comparable to previous studies, which were all defined by cardiac catheterization or coronary angiography in the past. And we may find out that that may make some difference as we continue to analyze the data. I think this is another important point. Again, patients with severe ischemia. So you could have stable, so-called stable ischemic heart disease, but if you had severe ischemia, for example, on stress testing with a fall in blood pressure with exercise, those patients were usually not included in the sites, as well as those that had a limited functional capacity and could not actually do well on a treadmill. And then they used this nebulous term, an unacceptable degree of angina, were patients that were also ruled out, as well as those with left main disease and the other areas that we talked about. But unacceptable degree of angina is often in the mind of the patient. In most cases, when pinned down, they defined it as having angina more than once per day. And as we know, many of our patients do have angina once a day. And those that appeared to do best and have the least complications were those that actually had angina, less, more like weekly or monthly, versus those that had it daily. And you showed this slide as well. I'll try not to be too repetitious, but again, the point is made that early on, what made the invasive arm look worse were that procedural MIs were increased early on following procedures, as we've come to expect. And however, down the road, after the 2 to 3, 4 years, spontaneous MIs were less in the invasively treated group. And also that all-cause mortality was low in both groups. So they had to have these extensive groups of outcomes in order to show any difference, really. And that was one of the criticisms, were that initially the secondary outcome of cardiovascular death and MI was the primary outcome, but they were actually not having enough difference in the patient groups that they actually appealed to the data monitoring board and asked for an adjustment, and actually flipped the primary and the secondary outcomes, so that the primary outcome could have much larger patient group to compare. And there is been some criticism of that as well. Again, ischemia is the largest trial in this area, far larger than any others, and probably because of the expense will not ever be repeated. So we need to try and learn as much as we can from this, and see if, possibly over time, both sub-analysis, as well as carrying these patients out further, will make a difference with how we see the ultimate results from this very important trial. Now, one point that you mentioned that I think I'd like to dwell a little more on is the analysis that John Spertus made from the Mid-America Heart Institute, and that was basically looking at quality of life and specifically utilizing the Seattle Angina Questionnaire score. And as we know, in stable patients with moderate ischemia, the question was, does an invasive strategy improve the patient's health status, their symptoms and function and quality of life? It's not just about their outcomes, but it's about their quality of life and whether or not you're actually reducing angina with an invasive strategy. And in this part of the ischemia trial, you can see that the patients were followed and questioned very closely at 1.5, 3, 6, 12, 18, 24 months and on out with the, again, Seattle Angina Questionnaire summary score. And the higher the score you have actually is better. And they also looked at not only angina frequency, but the quality of life as the patients recorded, as well as their physical limitations. And they had pretty high completion rates throughout the time of assessments. And they started off also asking exactly how much angina were they having for the previous 4 weeks, and used that to compare all the different groups. And really, this was still above 2,000 patients in each group were able to be analyzed according to their quality of life in the Seattle Angina quality of life score. And again, what you can see is that actually 1/3 of patients reported no angina in this study, actually more than 1/3. And then almost 50% or almost half had angina several times per month only, whereas those that were having daily or weekly angina was a fairly small percentage, around 20% or 1/5 of the entire group. So these were not patients that were having very frequent or very severe angina. So what was the outcome from Spertus's sub-study of the ischemia trial? And really what you can see here is that in every group at 3, 12, 36 months, that the invasive group had less angina overall by the SAQ summary score for the typical patient in ischemia. And those that were having daily to weekly angina, again, favored invasive in terms of less angina and better quality of life at 3, 12, and 36 months. And then also when we look at those that were having less angina, the difference is not as great, but again, still favoring the invasive category and treatment for those even out to 3 years. So their conclusions were that patients with stable CAD and moderate to severe ischemia had significant durable improvements in their angina control if they had the invasive arm, if they had angina daily, weekly, or monthly. And those without angina, there wasn't as much difference in the invasive strategy compared to the conservative group, as we might expect, because they weren't having much in the way of angina or none at all to begin with. But as you pointed out, Dr. Lopez, I would highly agree that in patients with angina, shared decision-making should occur to align treatment with the patient's goals and preferences, so that you can actually help them understand that you are doing this for symptoms, you're doing this for quality of life, and not necessarily doing this for, in fact, you're not doing this in order to try and prevent heart attacks or save lives. And I really like this algorithm that Dr. Spertus, John Spertus, has given us from Mid-America Heart Institute as a way to look at patients now after ischemia. You have those with stable coronary disease. Obviously, we want to have them on optimal 2 or 3 agent medical therapy. We definitely want to rule out left main disease by coronary CTA. And then if that's true, if they're having residual symptoms, the question is, have a discussion as to their preferences. And if they're unsatisfied with the amount of their symptoms, then consider an invasive approach versus those that are satisfied or content with medical therapy, then continue optimal medical therapy. But if they do have an invasive approach, which is done again for symptom relief and quality of life, again, the heart cath is done, and then a multidisciplinary approach as to whether or not they receive PCI or CABG may be in order. So you showed us the ESC guidelines, and I'll just show you that even these, I'm sometimes embarrassed at how old or how slow the ACC and AHA have with turning over their guidelines. But in this case, maybe that was something that is prescient. So these are still the same guidelines from 2011, and as you can see, CABG, as we've all been taught, is what's recommended for to improve survival and revascularization for patients with 2 and 3 vessel disease, particularly when in 2 vessels the proximal LAD is involved. But I think in the age after ischemia, again, not only is PCI of concern or of uncertain benefit, but we certainly have to take into account that we may have to rethink about our guidelines for CABG in these patients that can be well managed medically. So that's important that our surgical colleagues are also on for this as well. And then I'll sort of come towards a conclusion here, which is I thought this editorial comment that actually was in the New England Journal after the article you showed, Dr. Lopez, from Eugene Braunwald and Elliot Antman. I think it brings us a little centered as far as the results of ischemia, and I'll just quote them: provided there is strict adherence to guideline-based medical therapy, patients with stable ischemic heart disease who fit the profile of those in ischemia. Very important, and I'll go over this on my last concluding slide, but this profile is a very, although it seems like a large number of patients, we also know that it's the profile of those patients are stable ischemic heart disease, and we really need to keep our eye on that. That is the group that we're treating, who do not have unacceptable levels of angina, can then be treated with a conservative strategy. However, an invasive strategy more effectively relieves symptoms of angina, especially in those with frequent episodes. And again, that seems to be more 1 or more daily angina. And so that's a reasonable approach at any time in patients for symptom relief, particularly in like a heart team shared decision making with the patient involved in that decision, and understanding that it's not being done necessarily to prevent complications or improve outcomes, but being done for symptom relief. And that is very important, as we know for many of our patients, as we know that much of elective surgery is also done for symptoms rather than to improve outcomes. So then finally, I'll just say, okay, so who are the patients then that can still be recommended for an invasive PCI approach after ischemia? And certainly, I mean, I think these are unchallenged. The STEMI and the NSTEMI patient groups, we know that they reduce their mortality and subsequent infarction if they have a rapid delivery of care and reperfusion, and so that's unchallenged. Interestingly, I think because these patients were not selected in the ischemia trial, I think any patient that has acute coronary syndrome, and not only at the time, but also within the previous 2 months, we really need to rethink whether or not they are, quote, truly stable enough to be treated with medical therapy. And then again, we continue to push the unacceptable angina, which is in the mind of the patient, maybe more than 1 time per day. And then also, I think shared decision-making helps us know with the patient whether or not they feel that they want to go to an invasive approach. This is interesting. PCI or CABG within 1 year was ruled out from being included in the ischemia trial. So I don't think that we necessarily can say just because a patient is stable 1 year or less after PCI or CABG that they can be treated medically with the same outcome. We don't know that as yet. Although it seems logical, I think that remains to be seen. And then finally, I think it's pointed out by Dr. Marin Dave Marin at ACC 20, those that had very severe ischemia on stress testing with fallen blood pressure with exercise, or very limited functional capacity that really couldn't do a stress test very well. Those are the ones that we need to watch out for, and were not included in the ischemia trial, and we need to be careful that, you know, we're making a good quality decision for those patients. And then, of course, we know that 50% left main stenosis is definitely not even being tested here. So I'll finish with that. Excellent presentation, excellent discussion, and I'll stand by for questions. I think that interventional cardiologists will still have a role and still have a job.
Okay, thank you, Dr. Wilson. Great presentation. We have 5 minutes for the question. I have a question for Dr. Wilson. You described several limitations of this trial. And then the question is, according to the result of the ischemia trial, we have to change our everyday practice in this group of patients?
So I think that this does solidify the findings that we, you know, learned from the Courage trial more than 10 years ago. And I think that, yes, for patients that are stable, I think we are going to be less likely to pull the trigger, so to speak, to go to cath or intervention or surgery. I think it does point out that we need to be very clear on our discussions with our patients, with the shared decision making, that we are not doing cardiac catheterization for trying to prevent heart attacks or trying to prevent morbidity or mortality, and but that we're doing this for symptom relief, and they need to understand that. And I hope that we'll be better at informing our patients in that regard. On the other hand, I think that we will still have many patients who do not like to take 2 or 3 or more medications per day, and also are anxious enough that they would like to have relief of angina and just the idea of having something corrected. So as long as they understand that there's also, you know, 1% or less risk with these type of procedures, I think that we can have that healthy discussion with them. And yes, it may impact, I think it is already impacting the number of patients that we have for elective procedures. But I still think there will be plenty of patients that will want to go ahead and pursue a therapeutic result. It's interesting, last point on that I'll say is it's probably not going to be as affected as we have been affected lately by the coronavirus and patients being scared to come to the hospital anyway. And I know Dave Marin pointed this out, that when the ischemia trial ACC 20, that you know, the coronavirus sort of reinforced that maybe patients do okay by just staying at home and being treated medically. Okay, thank you. We have 1 minute for one question for Dr. Lopez. In your practice, the coronary CTA is fundamental to select any strategy in this group of patients?
Actually, I don't think we actually need the CTA. Of course, if you have the more information you have, it's better for the patient to have your decision. But as you see, we have to be assured that the symptom of the patient is related to ischemia. That was the rationale to use the functional test. So if you think about the chest pain challenge, that most of the patients have chest pain, fewer of them, the chest pain is related to ischemia. So the functional test is a way to see the relation between the ischemia and the chest pain the patient is feeling. Actually, of course, we can see that patients with high-risk ischemia, with low ejection fraction, drop in ejection fraction from the rest to the stress part of the functional test, with dilation of the myocardium in the stress test. This also, they are predictive of higher risk patients, and mostly of these patients are left main or triple vessel disease. So I don't say we, of course, need the CTA for every patient. I think it was equipoise, as I pointed in the presentation. But of course, in the low-risk patients, as the guideline pointed out, the CTA should be probably the first study. And for the high-risk patients and the patients with already disease, so this would be, or the functional test would be better.
Perfect. Great speaker, great presentation. I appreciate so much for the quality of presentation. And I would like to announce in Spanish. Los esperamos el próximo martes. Tenemos dos tópicos excelentes en cardioacademic, amiloidosis y sarcoidosis. Y también se hablará de inteligencia artificial, que es un tema fantástico con dos profesores de alto nivel. Eric, pues muchas gracias. No sé si podemos concluir. Ok. Thanks a lot.
Sin problema. Gracias.
Gracias a
Muchas gracias.
Thank you so much, Harley, Rafael.
Thank
so
you.
much.
Thank you. Stay safe.
Rafael,
safe.
Harley, so good to see you.
Take care.
take care.
Bye-bye. Take care.
Thank you.
Thanks.